We are live, and I'm going to send the link for the YouTube live.
Nice painting in the background, Michael.
I think Michael O missed out on that. We'll just give it one more minute for everybody to sign on, and then we'll get started. Okay, great. Okay, great. So we're going to get started with this week's Miami Global Brain Tumor Symposium. Thank you all for joining us here. It's our 18th week doing this symposium. Just a quick introduction before we get to our speakers tonight. My name is Michael Ivan. I'm one of the brain tumor and skull-based specialists here at the University of Miami, director of the research at our brain tumor initiative, and director of neuro-oncology. I'm welcomed today by my co-directors, Dr. Ricardo Comataro is professor and program director, as well as the director of the UMBTI and surgical neuro-oncology. Dr. Morcos, professor and co-chairman of the neurosurgery department, director of cerebrovascular and skull-base, and Caroline Benjamin, who's our newest skull-base surgeon here at the University of Miami and director of the Keynes Laboratory for our skull-base dissections. I can't put on this symposium every week without the great help of our administrative team from both Sylvester Cancer Center and the University of Miami. Christina, Ingrid, Roberto, and Ignacio have done a phenomenal job behind the scenes and on our call tonight. And so I just wanted to say thank you so much to them. If you have any questions about either the University of Miami Neurosurgery or our symposiums, we're active on social media. You could follow us on Twitter, Instagram, YouTube, or you can go to our website, neurosurgery.med.miami.edu. We have symposiums not only on brain tumors, on skull-based cerebrovascular, as well as residency topics as well. Quick kind of heads up for tomorrow. We do a very similar symposium, cerebrovascular and skull-based. Tomorrow's topic will be more skull-based focused. It's run by Dr. Morcos as well as his co-panels. We're focusing on sinonasal cancer with Dr. Demonte from MD Anderson from a neurosurgery perspective, and Dr. Sargi from an ENT rhinology perspective with a great group of panelists. Additionally, a quick teaser for next week, we have these global brain tumor symposiums every week. We'll be welcoming Morcos Maldon from Sao Paulo to talk about management of brain metastasis. So please be sure to sign up and tune in next week, same time. Quick housekeeping for all participants, please. We want to make this as interactive as possible. Use the Q&A button at the bottom to ask as many questions as you want. We'll try to get to as many as we can. We don't offer CME, but we will give you a participation email. And please be sure to like, follow, and share our videos on Instagram, Twitter, and YouTube so we can continue to grow. This week, we have a great group of panelists, starting with Dr. Gustavo Pradella. He's an associate professor at Emory and cerebrovascular and skull-based specialist there. He's also the chief of neurosurgery at Grady Memorial and co-director of their skull-based surgery center. Michael O, co-resident of mine. He's a brain tumor and skull-based expert at Methodist Moody's Brain and Spine Institute at Methodist Dallas Medical Center. He's also director of neurosurgery at Methodist Richardson Medical Center and the vice chair of the Department of Surgery at the same center. And also we have Dr. Zachariah, associate professor and co-director of neuro-oncology at Penn State and director of the brain tumor and skull-based program. Thank you all to all the panelists. This week, we have a phenomenal speaker, very, very near and dear to my heart, and I'm very glad he's joining us today, Michael McDermott. He's the Chief Medical Executive of Miami Neuroscience Institute and Professor of Neurosurgery, as well as the Chair and Division of Neuroscience at the Herbert Wertheim College of Medicine at FIU. It's a new position for him, so congratulations, Dr. McDermott. He just departed from UCSF as a professor and vice chairman and their residency program director, as well as the Wolf Family Endowed Professor of Meningioma Research. He was also the co-director of Gamma Knife and Cyberknife Radiosurgery at UCSF. Dr. McDermott is the guru on meningiomas, and we're very, very excited that he chose that topic to talk to us today about. Of his more than 400 papers, I would say about 2/3 to a half of them are devoted to meningiomas. And his research has really just brought the field of skull-base and meningioma surgery to the next level. And for me, I'm very lucky to have him as one of my biggest mentors for skull-base and brain tumor surgery. And you can see the picture there on the left of my last day of residency rounding with Dr. McDermott, as well as with some of my co-residents, all of which who were equally as inspired by Dr. McDermott and have all gone into skull-base and brain tumor surgery. So there's no question that he's impacted many of us, and very thankful for him to join us today. So Dr. McDermott, thanks again. And if you want to start sharing your slides, we appreciate it.
Hope this works. What are you seeing there?
Okay.
Okay.
There you go. Yeah, that's great.
Okay, well, thanks, Mike, for that introduction. I think it's nice when you get older that you see that the people you help train are doing good things. And Mike was, as you mentioned, one of our residents, so was Michael O. And I think Gustavo I've met, and Brad for sure I've met, but I know all the other panelists and co-directors here. So it's indeed a small group. I don't have anything to disclose relative to this discussion. I wish I did, but I don't. I thought I'd give a little bit of a historical perspective. I can't present everything in a short period of time, and I know that the panelists have some interesting cases, which will be interesting to review. I'm going to review some of the recent clinical results. We have, I think from UCSF, 3 more papers that are going to be coming out pretty soon. And I want to talk for some of the younger participants and residents about some of the lessons I've learned. I arrived in Miami February 24th, started work March 2nd. On March the 8th, we were shut down. We were doing emergent cases and urgent cases such as brain tumors that were symptomatic, metastases, malignant gliomas, AVMs, aneurysms. The 2 Michaels would be keen to know that I've actually started helping out with the cerebrovascular surgery as an assistant again, using the bridge for the microscope to do the aneurysms as they remember. It's been a lot of fun. As Mike said, I spent most of my career at UCSF, and I had a great experience there. You can see what the distribution of my surgical practice was, and I thought it was important for a tumor surgeon to be involved with radiosurgery, because that's certainly another tool in the toolbox for a tumor surgeon to be able to consider and use. It was about 33% of my practice one year, as you can see there. And I think that one of the things I've tried to point out in the literature with recent publications is that, surgery is not the only answer for these tumors. If you look at a recent paper from Mayo Clinic a couple of years ago on the 20-year follow-up for benign skull-base tumors, including vestibular schwannoma and meningioma, the recurrence rates after surgery in the order of 50%, and that's consistent with papers from Europe and Teat Matheson for parasagittal meningiomas. So, one of the problems with continually operating for recurrence is the side effect profile with repeat operation. And I've published that for both the cranial base and the cranial vault. And so I think we should consider additional options for treatment, including radiotherapy and radiosurgery. I don't have to tell this audience that meningiomas are the most common primary tumor after the age of 35 until death. Gliomas as a group outnumber meningiomas, but as an individual diagnostic entity, meningioma is more common than glioblastoma. One of the problems for us in directing our patients on decisions for treatment, if they're symptomatic, is the lack of good natural history information. And here are a couple of papers that you can see where the average follow-up in a review of surgical series was actually very short in the natural history of meningiomas. And I mentioned the Mayo Clinic series of 20-year follow-ups. And that's what's really relevant, because young patients have a longer life expectancy, and therefore they have many more years of risk exposure for recurrence. And so I think you need to be particularly, you can be more aggressive with younger people. However, if it's the difference between a gross total resection and deficit and subtotal resection with good neurologic outcome, I think it favors the patient to be less aggressive. If you give them a new deficit with your first operation, they will live the next 52 years of their life with that deficit or worse. And so we have to be very careful when we're recommending treatment for patients. And of course, incidental meningioma should really never be offered surgery upfront until there's documented growth or development of symptoms specific to the tumor site. This is that paper by Teet Matheson on 25-year follow-up. Recurrence rate, as you can see there, was it's about 50% at 25 years. And in that period of time, half the patients had died. And of those that died, half died from their meningioma or treatment, and the other half died from unrelated causes. So I think the follow-up for meningioma patients is not the global 3-month period after surgery, but the next 25 years of their life. And I think it's important for neurosurgeons to consider their colleagues in neuro-oncology to assist with some of that long-term follow-up so that we can keep our surgical practices active and unburdened, and be able to treat the newer incoming patients who actually do need surgery. In 1937, Cushing said that meningioma surgery was difficult, and we can imagine because, there was no microsurgical instruments, electrocautery had just barely started, there was really no magnification, but, even in spite of the number of years that have passed, it still remains a very difficult operation to get a very good result, and we should be mindful of that. I'm going to discuss some recent surgical papers. The UCSF group, Steve McGill, who's been our recent chief resident, and others, I think they've had 15 papers in the last 2 years. I'm only going to pick 5 of them to discuss, and some of the things I'm going to talk about are, I think, relevant for the future. The University of Miami group has investigated the use of intraoperative Raman spectroscopy for a variety of different tumor types, and our experience at UCSF was that for meningiomas, you can tell right away based on the small tissue sample that it works. I'm going to talk to you a little bit about some of the new information from a tuberculum study, and then these other things, if I get through it, leaving enough time for the cases to be presented. So the radiomics project was something that David Raleigh, one of our radiation oncologists, and Olivier Morin, who's a radiation physicist, began to investigate along with radiology using some artificial intelligence data crunching, if you will, for a variety of meningiomas, 303 patients. So we used the UCSF data as the primary set, and then the University of Toronto meningioma group as a secondary confirmation set. There were 16 radiographic and 172 radiomic features that were evaluated. And radiologic features included the typical things that we include there, and the radiomic features were used to identify other features that might be predictive. But just look at the strata that are created by whether or not the tumor is multifocal, yes or no, size, large or small, ADC map, which is, relates to the vascularity, and it separates these patients out preoperatively solely based on radiologic findings. And then you can look at even overall survival using ADC, low, high intensity, with edema, yes, no, bone involvement, yes, no, and then same kind of separation, which is surprising to me. But we did the same thing for low-grade gliomas preoperatively, just based on imaging features, age, and KPS status back many years ago, and validated, and it had very significant predictive value for time to tumor progression and overall survival. Unfortunately, I don't think anybody except me uses it, but the radiomic features are features that might predict tumor biology and clinical behavior. So something as simple as how round is the tumor, ADC maps and statistical imaging features, ADC, hypointensity, higher grade, low spherosity, meaning irregular features, including mushrooming, increased local failure, decreased overall survival. And the predictive factors for an adverse outcome were the radiologic and radiomic features were both associated with a higher somatic mutation burden, DNA methylation status, which the Toronto group has published on, and then FOXM1 expression, which UCSF reported associated with a higher incidence of tumor recurrence. So when you combine the clinical information like patient age, KPS status, sex, as well as radiologic and radiomic features, you can develop very powerful predictive models. And I have to be honest, I don't completely understand the grids and the analysis that was done, but a large number of variables, so you kind of get like a heat map, like an IMRT radiation fluence map of the frequency of these phenomena that are listed on the X and Y axes here. And then it turns out to be very powerful in terms of predicting grade, local failure, and overall survival. And if you look at the pink line under local failure and overall survival, you can see that demographic and radiologic and radiomic factors are particularly powerful. Also, the integrated models predict for long-term overall survival, and they're superior to conventional model systems. So we should be able to use this information in the future to do so. And the group from Liverpool, England, have begun this with Michael Jenkinson, and it's available online. And you can enter patients' demographic and radiologic information, which predicts the biologic behavior in a large sample size from England, and helps guide clinical decision-making and recommended intervals for imaging follow-up. So these models show much better prognostic capability than what traditional things would do, especially simple histologic features alone. I'm going to switch gears now, talk about tuberculum cell meningiomas. When I was chair of the tumor section, I hosted a point-counterpoint on this, which didn't go so well. If any of you were there, it got a little out of control. But obviously a point of controversy, and I was interested with these tumors as to whether or not there were some tumor factors that we could see on imaging that might predict the degree of difficulty, extent of resection, or the outcome, and guide us as to when an endoscopic versus a transcranial route might be preferred. The original classification had things like tumor size, optic canal invasion, no canal invasion, one or both sides, arterial encasement. Pretty straightforward, totally arbitrary. I was the one that came up with this. And I thought it was simple to use. The tumor diameter greater or less than 17 millimeters, presumably once it gets past that size, it encroaches on the roof of the optic canal out over the clinoid, which is not an accessible location for endoscopic endonasal approach potentially. Canal score, more difficult potentially with a transcranial route than an endoscopic route. And we didn't know whether or not one canal involvement or the other was important. But we did know from the transcranial approaches, as you can see in the example here, that the optic nerve was routinely displaced laterally, and at least one point of origin for these tumors was at the junction of the proximal medial optic canal and the chiasmatic sulcus right at the tuberculum. And unless you drill out the roof of the optic canal, open the falciform ligament, open the proximal optic nerve sheath, you won't get this component of tumor. And the part that extends down the medial canal is actually not too adherent. It's right at the junction. If you can get that released, you can actually use a rodent microinstrument, and the medial canal portion comes out like a sausage. It's obviously a different situation when you're approaching it endoscopically, because you're approaching it from the attachment side first. And then arterial relationships, working 2D is, I think, more difficult than 3D. I thought the instrumentation, from my experience with the endonasal instrumentation and doing the micro dissection, was harder than doing it transcranial. So along with the group from Italy in Naples, who first reported this, Dimitris reported 7 patients early on with this approach with Capobianco and his group. I think we put together approximately 130 some odd cases, and this was the distribution, predominantly transcranial. I think the UCSF group was the driver for that, because the Naples group only submitted transsphenoidal patients. And then what we found was the higher the grade, combining tumor size, canal involvement, or arterial relationships, those tumors were more difficult and tended to be operated on with a transcranial route. And then the transsphenoidal tumors tended to be smaller. And so there might have been some a prediction that maybe the bias for adverse outcomes with respect to vision for the transcranial approaches was because you were starting with a worse tumor to begin with. But this was our original conclusion. Thankfully, 82% of the patients had better or stable vision. Recurrence rate was low, complication rate not insignificant, and CSF leaks with the TS was kind of expected. And I don't think there was one mortality. So we took a lot of heat on the first submission of that paper. Didn't get into neurosurgery, didn't get into journal neurosurgery. The journal neurosurgery reviews were longer than the paper was. So we ended up getting it in neurosurgical focus. So I said, okay, well, let's just get some larger numbers. So I wrote to every academic neurosurgical center in North America, I think, and several in Europe, Korea, Japan, Germany, etc. 40 sites agreed to participate, and we collected 953 patients, which we were going to present to you at the Congress meeting this year prior to the shutdown. And then we looked to validate whether or not our scale was of any use and what the trends and outcomes were with respect to vision, extent of resection, complications, and recurrence. Demographics, here's the transcranial group with 629, transsphenoidal 318. Some patients underwent staged approaches. Median follow-up in terms of months, short, only 26. Tumors tended to be a little bit larger for the transcranial group than transsphenoidal, and peritumoral edema about the same in both of the groups. This is pointing out the significant difference between the transcranial and transsphenoidal groups. And what's interesting is that when you look back to 2002, or 2003, when the endoscopic and the nasal approaches for these tumors was started and gained popularity and technical improvements around the world, that when you get to 2019, the approaches for these tumors is equally split between transcranial and transsphenoidal. So there's an increasing proportion of tuberculum cellular meningiomas operated transsphenoidally. We found that with respect to visual outcomes, you can see that 51% of the patients were better, 36% were the same, and only 9.7% of the patients were worse, including both different approaches. And I think this is a real credit to the surgical skill of our specialty taking on these tumors. And one thing I'll say is that one of my patients, Mike, one of the Michaels might remember, but was an architect who presented with a big tumor, had a bitemporal hemianopsia, operated on the patient. Things went well, took what I call quality control images for the family post-op, got it all out, drilled both optic canals. And we did that on Monday. And on Wednesday afternoon, the patient went completely blind. And we did a CT scan, no hematoma. We did angiogram. There was no supraclinoid, infraclinoid arterial spasm. We did intra-arterial verapamil. Nothing worked. The patient never regained his vision. And he's been on 60 Minutes twice with Leslie Stahl. And it actually reinvented his career, surprisingly, as an architectural consultant for the visually impaired. And that doesn't help me the way I felt about that case. But we did notice we had subsequent cases that about 2 days post-op, the patient started to lose their vision. We began to use pupillometers to monitor the pupillary light response objectively rather than having the nurses try and do it with a flashlight. So we could get quantitative information. We asked the patients to watch the clock face. We kept the patients in the ICU with elevated blood pressure for the first 2 days. So if you operated Monday, they couldn't come out until Thursday, and they had to have the same vision on Thursday morning before we'd let them out. And we subsequently published a paper, one about the patient who went blind, and then the subsequent patient whose vision we saved. And I had about 7 others, one of whom was a 34-year-old woman who we gave a subendocardial infarct to by elevating her systolic blood pressures to very high levels, but we saved her vision. And I would say about a month ago, a colleague of mine called me from university for advice the morning of the second day after surgery, same problem. The patient losing his vision. And I said, where's the patient? He said, he's on the ward. I said, send him right back to the ICU, told him what to do. And that patient recovered useful vision. I don't know what the ultimate outcome was, but that patient was able to read, see colors, could talk to his doctor, tell him what color his suit was and everything. So it was a big save. And that's one of the most important things I think I've learned about treating these patients is to watch out for what I think is probably microvascular spasm. And so you really have to stay on top of these patients, whether you do it transcranially or transsphenoidally. Please be careful in the postoperative period. Here are the visual outcomes. I better hurry up because I'm giving you too many anecdotes. Here's the difference in complications. You can see the transsphenoidal group, big difference, higher complication rate. And this is all CSF leaks. The leak rate declines significantly with the advent of the vascular nasoseptal flap. There are other techniques for closure which have been documented to be associated with a low leak rate. But you can see actually the complication rate is actually extremely low. And that's one of the takeaway messages for me was that, as a group, we're doing exceptionally well. We do good work. We should be proud of it, but nothing's ever perfect. And then in univariate analysis, if you look at risk factors for recurrence, it's actually the opposite of what I would expect. And that for a transsphenoidal approach, the likelihood of recurrence is lower. And it kind of makes sense because with a transcranial approach, the best you're getting is a so-called Simpson 2. But with the transsphenoidal group, you can get all the bone, all the involved dura. And if you get all the tumor, then it's a true Simpson 1. So an interesting and unexpected finding. These were the conclusions. Have a look for yourself. But I think one of the main takeaways is, if you choose the surgical approach appropriately, you can do well. The image that I've shown you there was still a tumor that we took on transcranially because of the lateral extension beyond the carotids, as you can see. Recurrence was less likely after gross total resection and with older age, more likely with higher grade tumors. And after gross total resection, the recurrence rate was for transsphenoidal approaches was 1/3 that of transcranial, so surprising finding. We did refine our predictive scale, found that there wasn't any difference between whether you had bilateral optic canal involvement versus any, so then that scale went to no canal involvement, any canal involvement, and it didn't matter how much the tumor was wrapping around the artery as opposed to just abutting it, so it was just pushing up against the artery rather than encircling it. That's the main difference. There were a lot of contributors. We listed 128 authors. The authorship page is a page and a half as a supplement at the end of the article. We listed these by the number of patients they contributed to the study. Let me see, 10 minutes. Hyperostosing meningiomas, I guess everybody has their own way to do this. One thing I would say is that I think it's a big advantage for neurosurgeons to do these cases combined with their oculoplastic surgeons, and I'll tell you why. But this was the clinical syndrome described by Cushing in chapter 17 of his book, and you can see that all the pictures here are all women. So this is painless proptosis in a woman with infraorbital lid swelling and temporal fullness when there's an exophytic bony component. And that's typical. If you see a male with this and bony erosion, that's a high-grade meningioma, not a benign one. The indications for treatment are for documented growth, soft tissue or bone, progressive proptosis, visual loss, and an unremitting pain syndrome. And what I did one day on a Saturday in preparation for writing up this paper was I took the skull that Dr. Charles Wilson had given me when I first arrived on faculty and bought some watercolors from Amazon and painted in green the bone that I thought you could safely remove without significant morbidity, and then bone in red, which I prefer not to remove. And there may be some potential in the future of preoperative reconstructed prostheses to be inserted pre-op, but I don't take the supraorbital or lateral orbital margin, don't take out the floor, don't go down the medial orbit. You can remove the clinoid. This is the view from above looking down into the anterior and middle cranial fossa, and the limits for me are the rotundum ovale eustachian tube and the temporomandibular joint. It's just too much morbidity to go beyond that. If we looked at our experience over about an 18-year period, the patients had calculated exophthalmos indices, as Bill Caldwell's reported, over a 6-month period. I thought I'd done more than 56 patients. I think I did close to, I know I did over 2,000 meningiomas between 1999 and 2017 April, but I thought I'd done more than this. But the data don't lie. There's the presenting symptoms, very similar to Cushing. 7 patients, or 12.5%, had recurrent tumors, and only 16% had histologically defined grade 2. Here's the reality. Gross total resection, only 30%. And I'll tell you what the compartment extent of resections were, which is important to know. Most of the patients had subtotal resection. 33% had adjuvant therapy, and complications incurred at not 3 to 5%. That's not what the complication rate is in the pre-op area when you're, so the consent's not done by the residents in the pre-op area. That means that the consent's really done by the responsible surgeon, and that discussion has to occur in the office because these are complicated cases. Here's the compartment extent of resection. Intraorbital did really not very well because the tumors extend back into the superorbital fissure, and if you try and take that out, you're going to end up with permanent extraocular muscle palsies. The intradural component, probably because it was only a Simpson 2, and then there's some cases where there's cavernous sinus involvement, but we did really well. We digitized the pre and postoperative tumor bone involvement on CT scan. We did really well with the extent of bony removal, so I was pleased with that. I thought I'd done well, and it showed that I did. Improved vision in about 90% of the patients, and double vision improved unchanged in 76%. And this is why you need your oculoplastic colleagues for the preoperative evaluation and postoperative follow-up. Bill Caldwell talked about measuring the proptosis index. He does not reconstruct the orbit, but you can see that the proptosis index, which is a relative ratio of the bad eye to the good eye in terms of position forward from any reference point posterior to that margin. You can just draw a line across the frontozygomatic processes here, and then just measure the position out to the lens, and then divide the bad eye position by the good eye. And if they're equal, 1 is perfect. If it's less than 1, you have N-ophthalmos. If it's greater than 1, you have X-ophthalmos. But you can see that the early postoperative and the late postoperative, the X-ophthalmos index improved significantly. We had 1 patient with N-ophthalmos that required revision surgery. One of the things that we do is at the time of surgery, we prep the patient's face out down to just above the nares, and we do put ointment in the eyes, do a tarsorrhaphy. We shave the hair back from the hairline about 2 centimeters, and then we do the case. When we're doing the orbital reconstruction, when we think we've got a good position, we turn the skin flap back, and then we expose both the orbits, and we look at the position of the eye with the oculoplastic surgeon who's in there helping. He or her has helped done the orbital component excision and help with the reconstruction. And if we don't like it, we can modify the prosthesis to get a good globe position. And then the last thing we do is he or she does what's called forced duction testing in order to avoid this problem, which was entrapment of the lateral rectus by the posterior component of the Titan MedPore implant. And this patient required a conjunctival take-back incision to release the lateral rectus, good cosmetic result. And then after this case, we never had another problem with entrapment because we checked it intraoperatively before we closed. So I would say the cosmetic results have been very good. Gross total resection is, most of the time not possible. Recurrence rate's not insignificant, about 25%. And for younger patients, if I have imaging evidence of recurrence and without clinical symptoms, I'll tell them that I recommend radiotherapy, because if I couldn't get it out the first time, I'm definitely not getting it out the second time. And I think the results of radiotherapy have been very good. I'm going to skip because I don't want to run out of time. I'll skip the things about some of the studies on atypical meningiomas, but what the audience needs to know is that the RTOG 0539 trial was a phase 2 prospective study looking at intermediate risk meningioma patients, particularly with a focus on grade 2. And the primary endpoint was 3-year survival. There's a prospective study, 48 patients, 3-year progression-free was 94%, far superior to historical results without radiotherapy. And the adverse radiation events were few, and there was nothing significant. So this was a study that is being followed up with a prospective randomized trial, phase 3 trial for grossly totally resected atypical meningiomas to observation versus upfront radiotherapy. When you're dealing with some of these grade 2s and grade 3s, one thing you have to be, I wasn't aware of this until one of my donor patients actually died from metastatic hemangiopericytoma for a small pea-size Falx lesion that caused a lot of edema and seizures. We took out her Falx lesion, did radiotherapy, recurred, radiosurgery, gone, and she died of a liver metastasis. So I became suspicious for more than 2 recurrences if the pathology grade was 2 or 3. This is a mediastinal recurrence in a patient that was fatal for a grade 2 meningioma that was controlled intracranially. And we had screened that patient because she'd undergone standard therapy, external beam radiotherapy, had recurred, we'd reoperated, she recurred again, and then we screened her. And so we looked at the result of the screening, and this is demographics for the entire meningioma experience in a time interval. But the key thing is that there were 28 patients that were screened, and there were 10 suspected lesions, 9 of which were biopsied. Of the 9 biopsied, 8 were Mets, and 1 was a lung cancer. And if we looked at the incidence of by WHO grade, and the predominance, of course, was that these were high-grade meningioma. So if you have a second-time recurrence for a grade 2 or grade 3, I think you should do an octreotide PET scan to look for metastases, locations, lung, liver, bone, as predicted. And there was no effective treatment for these things. So if you find them, it's trouble. And here's the number of recurrences, and you can see that the likelihood of metastases increases with the number of recurrences. It doesn't happen really after the first recurrence, but if they have a second recurrence in a grade 2 or 3, you really need to screen the patients. So here's the information, which I think is important. The positive screen rate in second recurrences was 36%, which is not insignificant. This matters because if you find liver metastases, then that will influence any decision you're ever going to make about operating on an intracranial recurrence for the third time. I'm going to skip the fertility treatment. We found a slight increased risk. I'm going to go right to the conclusions. And that is that, as Cushing said, 70 years ago, this surgery is complex and humbling. And the two Michaels know that I would always get upset if somebody ever said surgery was a chip shot, because we know that, a sural nerve biopsy was done on a wrong patient, and a sural nerve biopsy that got infected ended up with a below knee amputation. So nothing is a chip shot. Whether the patient's a prisoner or some VIP, same operation. You always do your best. Get help when you need it. I've had 2 vertebral artery injuries on meningioma patients who had retrosigmoid and far lateral operations. Both of those worked out perfectly well. Patient had no trouble. Why? Because I put my finger on the hole and called Dr. Lawton, who came in and operated around my finger and got proximal distal control and sewed it shut, and the patient did great. So make sure you get help. Be honest with the patient and families when something happens intraoperatively, like the drill catches a cottonoid and pulls the string at 70,000 RPMs across the roof of the orbit, cuts everything except the globe, and you sew it back together, and then the patient wakes up with a complete ptosis and inability to look up. You got to tell the family what happened. And as Dr. Wilson said, it's okay to make a mistake, but it's not okay to repeat them. And you can learn from your experience. And obviously I need to thank the patients who let me operate on them to develop this experience. Mitch Berger supported me, my surgical colleagues, Mike Shagru, Steve McGill, and my nurse, Jennifer Viner. Thank you.
Great. Thanks so much. Those are some very helpful findings and very detailed. So we appreciate that. A couple questions that came up was for follow-up for your meningiomas, specifically with grade 1s asymptomatic. What's your kind of plan for following them, and when do you intervene?
So my plan is a little more acute than what Michael Jenkinson would recommend for older patients with some calcification, dark on T2, where he recommends a repeat scan in 5 years. I do usually, if there's no edema, no unusual features, I'll do 2 6-month scans, then once a year times 3, and then 18 months times 2, 24 times 2, 36 times 2. If the thing is calcified and the patient's in the 7th decade, they usually, those don't grow. So I don't follow those as closely. But that's kind of an arbitrary clinical schedule that I followed.
Another question was, what do you tell the new graduating residents that are trained now both endoscopically and transcranially when they see these, the experiences from very, very highly skilled neurosurgeons like yourself, publish the data on transcranial versus endoscopic? How do they kind of make these decisions? Do they just use the grading scale, or do they have to use their own skills? What do you tell them?
Well, I tell them when they go out and into practice, the first case you're going to do is not a tuberculum celli meningioma by yourself. Definitely, no matter how good you think you are, don't do it. Don't do a petroclival meningioma your first case, with your ENT. I don't do, as you know, I some of the really big ones, petroclivals, for example, I never did them as a single neurosurgeon. I had a neurotologist, and usually by the time I was, had enough experience, the max amount of time I'd be sitting down under the microscope was about 4 hours. When I started, it was like 6 to 8 hours. We would be finishing at 2 in the morning, and you remember Wednesdays, it was brutal. I became a little more conservative, like Dr. Spetzler, as I got older. And was willing to leave behind some tumor if I thought the risk was too high. And the same kind of decision-making intraoperatively also applied to vestibular schwannomas. Big difference between the clinical outcome for a patient with a normal face and no brainstem dissection, for a 10% residual versus gross total and, a rec. And the recurrence rate still in the Mayo Clinic is 49% at 20 years after gross total resection of vestibular. So I think you have to be a little bit tempered. I love it when everything goes great. I mean, we all do. But as we know, 25% of the time it doesn't.
Any difference in your follow-up for premenopausal females versus postmenopausal females for meningioma?
No. And I don't prohibit the use of hormone replacement therapy for postmenopausal patients if they feel well. And I think we've all had the experience of a patient with, I mean, we don't know what the denominator is for example, pregnant patients with meningiomas. The only denominator we know is pregnant patients who all of a sudden get symptomatic, right? And we know that I've seen people that have come in and they had a couple of kids in the last 5 years, and for sure their hyperostotic skull-based meningioma down in the occipital bone and condyle been there for a long, long time. And they were, they had a concussion, got a scan, and then now it becomes an issue. But so I don't really prohibit. One time at a Japanese meeting, we took a show of hands who would prohibit use of hormone replacement therapy, and it was a 50-50.
Okay, great. Okay, let's get to the cases. Gustavo, do you want to start us off?
Sure. Yeah, let me start sharing my screen here. Okay, great. Dr. McDermott, that was terrific as always. I had a couple of cases. You touched on tuberculum meningioma, and as you very clearly put it, there's progressive adoption of this worldwide in terms of endoscopic endonasal treatment, but olfactory groove and planar meningiomas still are those very hotly debated topics, and people get very animated in our panels and meetings about them. And I wanted to present this one to get your thoughts on how this has evolved, because I know you adopted endonasal surgery a while back, and you have that joint perspective. So this is a 62-year-old patient that presented with progressive anosmia over the course of 2 years to complete anosmia, and then he had a seizure. That's how he was diagnosed. So it's not a very large lesion. There's a fair amount of bifrontal edema. The anterior cerebral arteries are about a centimeter away from the capsule. And if you look on the sagittal, the tumor has broken through and it's in the anterior ethmoids. So what would be your thought process on selecting an approach? Are you doing any of these cases in the nasally, or are you not doing them?
Yeah, so the way at UCSF, the way things were split, like I would do this right cranial orbital, and I would do it microscopic, not endoscopic assisted. One of the things we showed, you're getting there with the coronal imaging, but if you look at the roof of the orbit down to where the back of the crista galli is, it's about 1.5 centimeters down. So the convexity of the roof of the orbit really dips down to where the olfactory bulbs lay. And unless you, and I can, Mike Ivan remembers a case that we did where we didn't take off enough of the bone medially to get flat to the lesser wing of the sphenoid, and there was an artery coming out from the posterior ethmoid. We just couldn't stop. And I don't know if you remember, Mike, I ended up flipping the dura back and going extradurally again to get the remainder of that bone off so we could get that artery. And once we got that artery, then the rest of the operation went much easier. So I think if you, the question is whether you want to do a single approach or a combined or stage approach. Obviously, the stage approach has more morbidity. The difficulty with the T2 signal endoscopically is the adherence between the inferior frontal lobes and the surface of the tumor. It's not the ACAs, it's all these little peel vessels that are been attracted for ingrowth by the tumor. And that's what I would do. I'd probably do this still transcranial and it's under 3.5 centimeters. So I do right frontal cranial orbital approach, supraorbital margin, roof of the orbit off, so I could get low and do it that way.
When you do your drilling of the hyperostotic segment, how aggressive are you with the drilling? Do you drill until you see mucosa?
No, in a 62, well, yeah, for tuberculums I do. For this, I probably wouldn't. I would drill until I saw something that maybe resembled cortical bone on towards the nasal side. And for a 62-year-old, I might, I probably wouldn't convert it to a transbasal, just because the risk profile is a little bit higher. I guess it would depend what I found intraoperatively and whether or not that I don't see the corresponding coronal that shows me that it's broken through the bone into the nasal cavity.
Mhm.
But I think I would drill the bone down to like saw more like cortical bone than cancellous bone involved by tumor and leave it at that.
And what do you normally do for your reconstruction if you do get through and you're staring at mucosa?
So if the mucosa is intact, like for tuberculum and angioma, I always drill the region of the limbus and chiasmatic sulcus. And I usually dissect the sphenoid sinus mucosa away from me and then put some gel foam on top of it to kind of protect the mucosa. If the mucosa is intact, it's really rare for the patients to get a CSF leak. And I initially used to place fat there, but the radiologist kept calling it recurrent tumor or residual tumor, so I stopped doing that. And I just put a little piece of pericranium down and sutured it with one anterior suture in place. I didn't use any fibrin glue or anything like that. And I think I had 2 CSF leaks. So it was with the transcranial approach for olfactory groups. Karina von Koch um, published that paper for us. So it was really rare. If you have a big defect, like if you're doing a sinonasal malignancy, like you're going to talk about next week, then that's different kettle of fish, and that's usually a excision of the inferior dura, a xenograft sutured in place, then the vascularized pericranial flap down over that. I don't put any free bone flaps, or I never put any titanium mesh to reconstruct the floor. It's not necessary. If the patient develops a subsequent encephalocele, then I will use one of those absorbable meshes, and we usually do a radial forearm flap for that.
Mhm. Well, for the reasons that I mentioned in the presentation, patient was anosmic, had a lot of edema, and it was not a very big tumor. We did this endonasally, and it was pretty favorable. We were able to identify the anterior and posterior ethmoidals pretty early and cauterize them, and then the tumor was very devascularized at that point, and the resection was pretty uneventful that way. But the reason I brought it up is because many people, Juan Carlos Fernandez, for example, Miranda, he has walked away from doing a lot of these cases endonasally if they have anything greater than 3 centimeters because of concerns with the reconstruction.
Yeah.
Um, but we are selectively doing some of
Yeah.
these this way.
Yeah.
This is the final resection, and the patient did very well. The other case I wanted to just get your thoughts on was this one. And this is an interesting 56-year-old gentleman who was in an academic center in New York City and had 2 meningiomas. One was an olfactory groove, and the other one was a convexity. And he had a bifrontal craniotomy and had a grade 2 meningioma. And he declined radiation therapy at that point and then presents with that type of recurrence.
Well, that's, the question is, it doesn't look like it's too far lateral, and he's not had radiotherapy. So I think I would try this endoscopic endonasal with repair and then use radiotherapy post-op.
For your olfactory grooves, I guess the question goes back to the other question I asked you. How aggressive are you with your olfactory grooves in terms of going after the whole hyperostotic segment?
Yeah, you know, in reality, the degree of hyperostosis with olfactory grooves is actually quite minor. It's not a big, it's not like a sphenoid wing hyperostosis. And the bony involvement is usually minor. So as I said before, I don't drill until I see mucosa. I usually excise the dura and drill until I see what looks like cortical bone on the nasal side. So I don't do what Sam Mefti does and cut everything all out and graft it and everything. I think it's too morbid on the first operation.
And in your gross total resections or near total resections for grade 2s, what is your radiosurgery counseling for the patients?
So my counseling is for any subtotal resection of a grade 2, I recommend radiotherapy, not radiosurgery, because the problem with using radiosurgery is you're treating only part of the problem. So the volume at risk is all the original preoperative dural attachments. So if you use radiosurgery, you're going to end up cherry picking over years with multiple little small recurrences around the edge. So we always use fully fractionated external beam radiotherapy to begin with. If the patients, if I get a gross total resection and the labeling index for the tumor is less than 7%, then I observe. If I get a gross total resection and the labeling index is above 7%, I send the patients for consultation of radiation oncology and let the patient and the rad-onc people decide, because we found that the labeling index was an important predictor of subsequent recurrence for gross total resection in grade 2 meningiomas.
Terrific. We did the same as you suggested. This was the hyperostosis on CT, and we did an intranasal resection. You can see the extent of the bony removal, and then follow that with radiation therapy stuff.
Yeah, great job, Gustavo. I always find it challenging when the olfactory groove meningiomas are anterior and involving the back of the frontal sinus. And that's kind of what I've been using lately is swaying me towards endoscopic versus transcranial, because I find it when they go so far forward, involve the frontal sinus, it's hard to get the nasal septal flap to reach that far forward, and then it's more complex to kind of repair that. But in your last case, I guess you probably didn't even have a pericranial flap even if you went transcranial, because it sounds like they already kind of took that away from you. So
that's right.
It's not really much of a repair advantage going from above versus below in that situation.
Yeah, one thing I would recommend is do not use any kind of muscle-based free flap. You don't need it up there. The muscle swells, as you know, unless you're taking out the orbit or if you've got a big defect, including the nasal cavity and its recurrent post-radiotherapy. All you need is radioforum microvascular free flap to cover that anterior cranial base for the first recurrence. Don't put muscle up there. You need a lot of trouble with swelling and, frontal lobe syndrome, et cetera, et cetera.
One other question for you, Gustavo, came in. So olfactory groove meningiomas that are smaller with normal olfaction, do you try to preserve one side, or do you approach those any differently?
I do, yeah. If they do have olfaction, I do either, depending on the size, it's supraorbital or cranioorbital.
Okay, great. Okay, Michael, you want to present your case? Just unmute yourself there.
There you go. Well, Mike Ivan, first, thanks for inviting me to this symposium. There's a lot of Michaels on this symposium, I just realized. Am I sharing?
Yeah. There you go.
Okay. Well, Dr. McDermott, thanks for that talk. I know when I first graduated from residency, I had consulted you on how to follow these patients. And so you gave me a nice list of how you follow these patients. And so I kind of try to incorporate that into my practice, but the basic idea that I got was to follow them as long as possible. So I really did try to incorporate that into my practice as well. Wanted to talk to you about this case. It's a 47-year-old lady with a 2 months history of progressively worsening balance problems, short-term memory problems, as well as urinary incontinence and headaches. Her balance was so poor that she actually couldn't really walk on her own. She had some serious language problems, including some problems with spelling, reading, writing, no focal weakness. She went to see her primary care doctor with the presumptive diagnosis of early onset dementia, where MRI was done, which showed a large enhancing mass in the ventricle. She did have some obstructive hydrocephalus with what appeared to be a benign contralateral choroid plexus cyst. So here's our MRI. The T1 with contrast shows a very large tumor with a enhancement. There's some necrotic centers in that area. You know, certainly our first diagnosis was meningioma, but when we're looking at this, we consider a lot of other tumors like ependymomas, METs, central neurocytomas and things, but meningioma was definitely the highest on the list. When we do these intraventricular tumors, there's really two things that we really focus on. One is the approach, and then the second is getting a good vascular control. Really, the approach for this is really the superior parietal approach. The problem in this case was that the tumor was so big, it was actually coming up near the surface there on the coronal image that you're seeing, where it was basically just behind the central sulcus. Dr. McDermott, do you have any thoughts on how you would approach this maybe differently than some of the other more typical angiomas?
Yeah, what I do now is, particularly when the occipital horn is trapped, I come in via an occipital transcortical transventricular route. Usually there's about 1 centimeter brain tissue there. If you come through the posterior roof of the occipital horn, you avoid the visual fiber pathways, so you don't create any new deficit. And then obviously, you know, you're in the ventricle, and then it's just a matter of dealing with, it looks like this thing's got calcification, so it's probably firm.
Yeah. Well, so what I did was we incorporated a sleep motor mapping. I actually ended up just doing the phase reversal. And as we know from these tumors, sometimes it can really remodel a lot of the fibers in the brain. And fortunately, her phase reversal, we went in and we exposed and actually found what we thought was a central sulcus with a large draining vein. But the phase reversal actually occurred 2 or 3 sulci anterior to that. So we actually got really lucky, and we could actually see the tumor coming right up to the surface. And so we basically went in through that area just behind the central sulcus, and then got into the large area of the ventricle there, and then began basically taking the tumor out. The second thought was about the vascular supply. Whenever we have these ventricular tumors, and when I get in, the first thing that I do is not start taking the tumor out, but I'll spend a lot of time just dissecting the tumor off the subependymal surface and going around and finding that vascular pedicle that's feeding the tumor. Most of these meningiomas always grow on the posterior occipital horn, where the blood supplies mainly come from the posterior choroidal. So if you can find that vascular supply and cauterize it, I found that a lot of times you'll start out with this nice pink tumor, and it'll just completely turn white after you take the vascular pedicle out. On this particular tumor, when we looked at the T2 scan, there were some extensive flow voids, and I don't know if you can see that very well in some of these scans, but what we started doing with these tumors is to get a diagnostic angiogram. I'm fortunate enough to have a partner, Dr. Bartley Mitchell, who's an endovascularly trained neurosurgeon. So he did this preoperative angiogram and found a very large posterior choroidal feeding this tumor with some really impressive vascular supply to the tumor. Dr. McDermott, do you have any thoughts on what type of tumors besides the intraventricular ones that you would recommend angiograms on?
Yeah, usually large convexity or parasagittal meningiomas. That's where you get most bang for the buck. Big petroclivals, I'll do it because now they can cannulate the meningohypophyseal trunk and some of the big monsters and get in there, and that, or ascending pharyngeal or muscular branches off occipital or anything. I'll take whatever I can get. I usually don't, even for neurocytomas and stuff like that, I usually don't do an angiogram for these anymore because they weren't able to embolize them. And as you said, if you fall not the subependymal, but the ependymal surface,
Mhm.
because as soon as you go subependymal,
Right. I meant the ependymal surface. Right.
yeah, that's when you get in trouble. So
Right. Right.
the roadmap for your anatomy in the ventricle is the ependymal veins. And if you
Right.
stay superficial or, those, then you're good to go. So, yeah, I wouldn't have done the angiogram, but I don't know if they were able to embolize this, did they?
They were. So I'll show you the next scan. So you can see the pre-embolization scans on the top and on the bottom. And again, I don't routinely do embolization on or diagnostic angiograms on these tumors, but this one was so big, and I saw some pretty wicked looking flow voids in the tumor that I thought it would be useful to at least get a visualization.
Sure.
This tumor was so big that there was no way I was going to get to the source of the bleeder before I got there. But you can see on that right bottom corner, there's a little vascular pedicle where the embolization stops in the posterior choroidal artery. And once Dr. Mitchell took that out, the vascular supply to the tumor basically died off. So when we got in, it actually made the tumor resection really easy. The tumor was pretty avascular, so we just went around the whole thing and took it out on block. She still
Michael,
has that.
Don't
sorry.
do that. You don't need to do that. Debulk the thing, and it's safer, much less manipulation to debulk the tumor centrally and then fold the edges in like eating.
That's exactly what we did. So
when you said on block.
Oh, no. I meant in a piecemeal fashion. So we went in, we took out little bits of tumor, collapsed it, and basically took out the thing in multiple pieces.
All right.
Yeah. So I think the two main thing with these tumors is definitely the access. I think the superior parietal approach is the best access for these tumors. And then getting to the vascular supply, whether you can do it by cauterizing the actual supply to the tumor or doing it angiogram wise. But a lot of times with an angiogram, it'll show you the map of where the vessels are, but they can't really get to it because the vessels are usually pretty small. But in this case, the vessel was big enough that they were actually able to embolize it. So that's all I've got.
Great outcome, Mike. Nice job. How long did you wait between embolization and surgery? What was your time course there?
I think for this lady was about 2 days. Typically, we don't wait more than say about 2 to 3 days. For this case, I don't think it would have really made that much of a difference. But for a lot of the other tumors, we try to get in there within the couple days because sometimes they can revascularize and open up other collaterals pretty quick.
Great outcome. Nice job. Brad?
Yeah. All right, everybody able to see that?
Yeah, looks good.
Okay. This is actually a woman that I saw on Monday, so I'm gonna cheat. There's no post-op here. I'm looking to get some help. Again, Dr. McDermott, thank you so much for that talk. I've always been really kind of impressed and inspired in a lot of ways by kind of your honesty about the complexity of these cases and the way you present them in the papers you publish. And I think that's lacking in a lot of the stuff that we see out there. So I truly appreciate that. It's definitely had an impact on the way I counsel patients and think about a lot of these complex meningioma. So this is a 57-year-old, really otherwise pretty fit, healthy woman. She was actually a former boxer. She's had 8 years of trigeminal neuralgia. Had just been managed conservatively over the years, never had any imaging or further kind of neurologic evaluation for that. But over the last several months, she's had some very mild imbalance. She's non-focal neurologically. She avidly exercises. It's not really limiting her in any way. But she gets an MRI. And I'll scroll through the axial contrast image here, which shows this, petroclival presumed meningioma. There's maybe some early evidence of mild hydrocephalus. And so play through the kind of the KISS sequences or these high contrast sequences. It's medial to the fifth cranial nerve. It sits above 7/8. There's a very small amount of flare signal change in the right temporal lobe. And so if you take a look at this just static image here, this is just a plain T2. This is, basilar apex with circumferential encasement of the
Uh-oh. Brad, I think we lost you. Let's give him a second.
He looks is still there.
All right, I'm sure he's probably trying to log back on.
Do you want me to comment, Mike?
Yeah, go for it.
Yeah, this is the lose-lose situation, right? Not the win-win. So.
Sorry, I dropped off there for a second. Let me pull that back up here.
Dr. McDermott was just starting his comment on the case.
Yeah. Oh, good. Yeah, that's what I can't miss. I promised, I was going to be talking to you. So.
Well, I was saying this is the typical lose-lose situation.
Yes.
Unfortunately, so it depends. 57, and how bad are her symptoms?
Not bad. Stable trigeminal neuralgia, which is not debilitating for 8 years. And there's more kind of, again, vague symptoms now, in particular, just some mild imbalance. What this is doing to the right optic nerve is pretty impressive. I'll try to kind of get onto this. It makes like a 90-degree turn outside the foramen, but she has no visual symptoms. I mean, this is the right optic nerve kind of coming out of the foramen, kind of just makes a hook here. She does not have visual symptoms, but has seen an optometrist, is going to be seeing an ophthalmologist to get a more formal exam, but no subjective symptoms really.
Yeah. So what I would do is do the full, like the visual workup first. I would check her hypothalamic pituitary axis just to be sure she's not impaired in some way. And then, it all comes down to examination and how debilitated the patient is. And if she hasn't had medical therapy for her trigeminal, that's the first start. And then I'd probably, if she was walking, talking, doing fine, just trigeminal neuralgia, I would probably wait 6 months and tell her, look, if X, Y, and Z happens, call me. If you're falling, then she needs surgery because she's eventually going to hurt herself.
Yeah.
And let's just say, okay, she's bad enough. Now we need to do something. The only good thing about this image is the fact that there's no edema in the brainstem.
Correct.
So, and I would tell the patient, look, I can get a lot of this, but not 100% of it for sure. This was a big one. It's bright on T2, so it's going to be softer. There's not mushrooming, and I don't know what the vascularity would be like. You could do a blood flow study, which most radiologists do now anyway. But I'd probably do an angiogram just to get a roadmap. I think that's the PCOM and the PCA on the image that's shown. Yeah. And then see if they get anything for the meningohypophyseal or ascending pharyngeal, metameningeal, whatever they can get to help me. I would enlist my colleague in neurotology. We do an audiogram tell the patient they're going to have conductive hearing loss for retrosigmoid. I don't think the posterior fossa component is huge enough for me to want to do a translab, although I was able to convince one of my colleagues to start doing a superior semicircular canal unroofing and the so-called transcranial. And several of the patients, actually their hearing didn't change at all. So I couldn't convince all my neurotology colleagues to do that. When the tumors are big like this, millimeters count. So I would probably say, look, you're going to get a conductive hearing loss, even if I did a posterior petrosal approach. And I would tell my ENT colleague, look, do a transcranial. If we can get just that little extra view inside, that'd be great. first thing I do after they did the exposure is what I've started to do is I've used the CO2 laser I try and identify the fourth nerve on the edge of the tent. But in big ones like this, I tell the patient I'm cutting it because it just, I mean, you work around the thing all day long. There's such a big supratentorial component. The fourth nerve is going to be in the middle, and I just cut it. And there's muscle transposition surgery can be done post-op with a small prism correction to give the patient binocular vision. And most of the time, you know, if you've done enough of these, you try and dissect it, you come back, and it's like a skinny, wet piece of spaghetti, and you've been trying to save it for 6 hours, and then it's in two pieces. It's really a shame. But, and that's what I would do. I would take the laser, follow the tentorial edge all the way down, and it's really hard to cut the tent. And when you look on the T2 weighted image, you can see that the dura is thickened. And so, you know, when you get to the most medial component of that tentorial edge, it's really hard to cut it with scissors. And that's what I would do. I wouldn't even bother looking for the back of the tumor debulking. I cut the tent first, and then you get much more room. And then I try and go right down the petrous face above the 7-8 nerve complex. I don't know where fifth will be inferior and medial in this case, but I try and go for
it out here a little bit.
Yeah, it might be lateral. Oh yeah, it's lateral. Okay, it's lateral and inferior. So good. And then I would aim for the meningohypophyseal vessels that come out on the medial aspect of the bone just below the entrance to Meckel's cave. And so if you can get down there, if you can get your bipolar down to the dorsum and just devascularize all, that's what I do right off the bat. And then I would usually work on the posterior fossa component first, and then you can fold forward the, but I wouldn't be too aggressive trying to get all the stuff out of Meckel's cave, because the supratentorial part is going to be the really hard part. You know, but sometimes if it's soft, it comes down, and there's a little bit of edema on the medial temporal lobe. I'm not really worried about that. If there was a bunch of edema up in the thalamus, then I think we were screwed. But it's not too bad. You know, you just have to get, if you're operating, you have to make the decision intraop. I mean, how stuck is it, and what's your pucker factor, so to speak, as to what you're willing to risk. And probably in this case, subtotal resection is better than gross total for sure with postoperative radiotherapy.
Yeah,
There's
I mean,
questions here. If it involves the optic canal, would you do a clinodectomy as well?
No, this doesn't involve the optic canal.
Yeah, I don't think it involves. I mean, it's you know, displacing the chiasm, but I don't think it involves the actual.
Oh, the one thing, Mike. Well, maybe underneath there, but you know, the visual Humphrey visual fields will tell the story about what the visual compression is. I mean, Sammy would do this in 2 stages. He'd do retrosigmoid first, which I find incredibly. It's 12 centimeters from the retrosigmoid approach to the you know, deep side of that tumor in the mid-clivus, and you cut it down to about 8 centimeters with the retrolabyrinthine or transcranial approach. And so I would never. I don't really like doing that, especially when the supratentorial part is so big. You can do pretty well with a single stage posterior petrosal approach.
Yeah.
Okay.
Yeah, no, I appreciate the advice.
Yeah, and tell the patient the likelihood of a transient new neurologic deficit is 100%.
Yeah.
It's not, you know, it's not 5 to 10 or 12 or 15. It's 100. You can have conductive hearing loss no matter what from opening the mastoid. You have new facial numbness for dissecting the 5th nerve. You know, 8th and 7th a little bit at risk, and then, you know, risk of stroke, etc. So it's really tough. I remember once I followed a patient with something like this, some hillbilly kind of guy that came from Northern California for like 7 years. I said, well, I don't think, maybe we'll just, you know, image you. And the thing never grew. And he kept, you know, kept coming in, hey, doc. And I was thinking to myself, God, if I'd operated on this guy at the beginning, he was basically, it was kind of an incidental finding or something. He didn't have much. And I didn't feel like I didn't think I should have operated on him because I knew I was going to cause trouble, at least in the short term. I'm glad I didn't. But, you know, on the other hand, you get like a woman in her mid 40s who's a U.S. ambassador with 3 kids and a big tumor bigger than this. That's like, oh my God, you just want to like, really? Do I really have to do, am I the one that has to do this? But
I've encouraged second opinions.
yeah, but no, but you know, in that case, I told the patient the absolute truth, cut her 4th nerve. We did angioembo, everything worked out fine. She had eye muscle surgery. We did post-operative therapy. I think we did, it was, the tumor anatomy was favorable. So it wasn't like it was, you know, the skill of the surgeon. It was just that, like you have here, a nice arachnoid plane. There was no edema, and it actually worked out well. So we had one just before I left UCSF where it didn't work out well at all, and it was a disaster.
That's incredibly helpful.
All right, in the last 2 minutes, I have one more because we have a couple questions talking about recurrence. And so I have a quick case that just, I think, will kind of help with those questions. If you have another couple minutes, Dr. McDermott.
Yeah.
Okay. So is a 51-year-old female who presented at outside hospital, worsening headaches, facial pain, some fainting spells, probably seizures in 2017. She underwent surgery by the outside surgeon, and he did kind of like a 50% resection, maybe 75% resection.
Of what?
Left some tumor because it was encasing the PCOM per the reports, and it was a grade 1 meningioma at the time. Ki-67 was 2%. She came to us a couple months after that, and because there was residual, I think she was at that, she saw radiation and they recommended radiation. She was denied that and lost a follow-up and shows up a year and a half later with this. Large left-sided meningioma, T2 with edema in the temporal lobe and lots of flavoids here, almost arising from the posterior clinoid, all supratentorial.
We don't see any images, Mike.
Oh, let's see. There we go. Sorry about that.
All right.
Let's start again. So here's the pre-op image. Sorry about that.
All right.
So small left-sided tumor, kind of arising posterior clinoid, involving some of the PCOM at that period of time. I don't have the post-op scans from that surgery, but represented now with this kind of very fast growth over less than 2 years in the posterior aspect, kind of posterior clinoid again, lots of flavoids, edema in the temporal lobe, all supratentorial.
So this reminds me of a case I presented at CNS with Dan Barrow, Jacques Marcos, and Robert Spetzler, called Desperate Intraoperative Moments. And the vascular surgeons were all talking about, aneurysm rupture and all that stuff. But I presented a case just like this, where the patient woke up intraoperatively when I just devasculated. I was coming down the sphenoid wing, the lateral wall of the cavernous sinus, along the edge of the tentorium, and the patient literally woke up because the anesthesiologist had given herself an overdose of fentanyl. And so we had to abandon the case. And these posterior clinoid ones are really difficult because the majority of the tumor is up behind the MCA. That's the trouble. And I would, I don't know whether I would certainly do a preoperative angiogram, see what's up. Hopefully they could embolize something. Right-handed, presumably, right?
Yes.
And she has language trouble already?
No language problems. She's still working as vice president of her company and
no.
high functioning.
Yeah, no, I think this, this is a pay me now or pay me later, unfortunately. And the pay me later is even worse than pay me now. So I would do the angiogram. I would probably, it looks like did they do a cranioorbital approach the first time?
Just a craniotomy.
So I would do an OZ approach for this, like including the arch, so I could get low and have the patient's neck the head extended on the neck so that you were looking more under in the middle fossa plane kind of thing, because you want to be able to look up, actually up behind the MCA to try and get this out. And a lot of those signal flow voids are veins on the MR scan, not arteries. They're just big draining veins. So hopefully you could get some hit with the dissection of the base and devascularization there, or embolization. If it got tenuous intraoperatively, or it was long, really difficult, there's no problem with, staging it, meaning you're at it for 8 hours, you've got the base detached and the thing's just not coming down, and you're waiting. On that lady that I had to abandon the case, all of the tumor that you see above the posterior clinoid was infarcted. So when I went back to take it out, it was like purple toothpaste. And I just took the Dr. Wilson Penfield #1 maneuver and went around the capsule of the tumor and, took it out.
Yeah, so I did what you said, an OZ coming from the left,
Yeah.
and we took just a little bit of the anterior temporal tip because it was very difficult to reach that area. And then the whole medial aspect, the anterior choroidal was encased, the PCOM was encased, and all of the kind of the perforators coming off of the PCOM were also encased medially.
Yeah.
I wish I would have gotten a little bit thinner of a wall, but it is what it is. Pathology came back as a grade 2, Ki-67 was 4%. So she did fractionated radiation and tolerated it well. She's still doing well, neurologically intact. And now, kind of a year and a half later, starting to have some regrowth. And there's been about 5 questions about what do you do for kind of tumors that come back after radiotherapy? What is your paradigm for treatment?
So what I would do, the molecular markers, including got a mental block now, but looking for potential for targeted therapy with drugs. And then what's her visual status?
Her vision's still normal.
Yeah. Well, I'd get out the old pathology and send it back to the pathologist, say, hey, look, can you look for, I just looked at this about a month ago. There's only one clinical trial that's open for recurrent meningiomas for chemo. And
yeah, it's like the SMO, ANF2, and
it's a dual agent treatment.
Yeah.
And I would look at that first and try that first on a wing and a prayer. And if the patient got a radiographic response or stabilization, I just keep going as long as they could tolerate it. And the neuro-oncologist said it was fine. If the patient, if it didn't work, then I think you're going to have to do like 5-session radiosurgery or something. But reoperating, it's perforating artery. You can't do a bypass. You can't do the Bill Caldwell bypass maneuver for this because you can't spare the perforating arteries taking the tumor out.
Right.
You'd end up with a Triple H syndrome, and this is just a bad behaving tumor.
Yeah. For your I-125 therapy, obviously, do you do those just for convexity recurrences?
You have to get them down to 1 to 2 millimeters of residual.
Okay.
So like putting an implant on the lateral aspect of that meningioma wouldn't do anything.
Right.
Because the penetration, they're soft, low energy KV photons, so they won't get to the medial side of that tumor.
Okay, great. There's about another 10 questions, but we're already kind of well into the night, and I know Dr. McDermott has a lot of things to get to. So I just want to thank him again for his time, and thank all the panelists. I really appreciate it. Those are great cases with great outcomes. So thank you so much.
PD-L1 receptor antagonist. That's what I couldn't remember.
Got it. Yeah, that was one of the questions here.
Yeah.
Okay, thanks everybody. Please stay safe.
Thank you.
Michael, be safe from the hurricane, okay? Hopefully, I think it's gonna go north of you there, right?
Yeah, thanks.
All right.
Bye, guys. Thank you, Michael.
Thanks.